Assalamu alaikum. Today we will start the second part and the last part of TGA. As we mentioned in the previous lecture, we will have a hint about how to calculate the Qbqs in the TGA. Then we will start by how to evaluate a TGA after repair. TGA in itself is indication for a repair. So we will not discuss the indication of repair of TGA. You have to correct the TGA. My question is, when I have to worry about the Qbqs in TGA patient, when it's associated with what lesion?
With VSD.
With VSD. With a hemodynamic significant VSD, right? Exactly. So when I have a TGA like that, this is a peristernal view. This is the LB giving a branching artery. This is the pulmonary, and this is the RV, and this is a VSD. So as we mentioned, is it mixing or shunting in that case?
Mixing.
It's mixing. But we expect also to have some shunt with that, but it's in the first stage, it is mixing. So in that patient, we have to calculate the Qbqs. What does it mean, the QP?
Flow in the pulmonary?
Not in the pulmonary. So if we say it in that way, flow in the pulmonary, so it means the flow in the pulmonary artery. We mean the effective pulmonary circulation. And the QS is the systemic circulation. So the question now, how to measure the Qbqs? The traditional way, and we have to admit it is gold, it's old but still good. The Fick method by Kath. Actually, it's a brilliant method. Fick method is named after the Professor Fick, and it is a simple way of thinking, but it's still clever. That if you have a dissolved thing, that you can trace it in the start of the circulation and the end of the circulation. If you subtract the amount of that tracer, you can have an idea about the flow. So if we have something started with 100, it ended by 40, so this circulation consumption is 60. And if you have circulation that started with 100 and it ended by 60, so the consumption is 40. So we have to have a tracer in both circulation, the pulmonary and the systemic, and we have to be able to trace this tracer. And in addition, we have to know the consumption of this tracer. So what is exchangeable between the both circulation, the pulmonary and the systemic? It was the oxygen, the cheapest tracer that we have. So Professor Fick said, if we can trace this tracer, the oxygen, in the beginning of the circulation and the end of the circulation of both pulmonary and systemic circulation, and we know the oxygen consumption is constant, so we can have idea about the flow. So the beginning of the pulmonary circulation is?
Pulmonary artery.
And it ended by pulmonary veins. And the systemic circulation?
Is VC and IVC and aorta.
Cava or right atrium, exactly, and it ended by aorta. So the flow will be oxygen consumption, which is a constant, and the difference between the beginning and the ending of the circulation. So the pulmonary circulation, the Q is for flow and the P from pulmonary. So the QP will be the oxygen consumption constant divided by the oxygen difference between the pulmonary artery and pulmonary vein. And the systemic circulation will be the oxygen consumption constant divided by the difference in the oxygen, the tracer, in the aorta and systemic veins. And now we have to have the ratio, the QP over the QS. So back to some math basic education, that this is QP, oxygen consumption constant, divided by the difference between the pulmonary veins and pulmonary artery. And this is oxygen constant divided by the difference between the aorta and the cava artery. So if you have numerator and denominator divided by each other, so it changes to multiply, but you will flip this. So aorta, the difference in oxygen will be the numerator and the oxygen consumption will be down. So we say the oxygen consumption constant, everybody following that if you divided numerator and denominator, you have to flip it up. So oxygen consumption is a constant, so we can just eliminate each other. And we have here aorta minus right atrium oxygen consumption and the difference oxygen consumption in pulmonary veins and pulmonary arteries. Is it clear?
Yes.
So instead that we say QP over QS, but we started by the aorta, not by pulmonary vein, because we flipped each other by this mathematical equation. Okay, I'll give a simple example about a case of VSD. So we have radial or the aorta oxygen saturation is 90 and the cava saturation is 60. Pulmonary veins oxygen saturation is 100 and pulmonary artery is 90. So if you would like to do Qbqs, how do you do it?
3.
So we will start by the aorta. Remember that we say Qbqs, but we started by the aorta. So 90, subtract 60 from 90, it will be 30. And subtract 90 from 100, it will be 10. So it will be 3. So the Qbqs is,
3.
what does it mean?
The pulmonary flow 3 times than systemic.
Exactly. This is a significant left to right shunt, so we have 3. And we have, so is it clear about the VSD? Okay. We have something different when we talk about the transposition of great artery, and we want to talk about the single ventricle. It goes for both of them. So, first of all, in the Fick method, there is a rule of thumb that oxygen consumption rate will be fixed in the systemic and pulmonary. But when you have a patient with heart failure, so he will have hypoventilation or ventilation perfusion mismatch, or another way he has a low cardiac output. So in the systemic way, the oxygen consumption in the systemic and pulmonary circulation will not be equal. So this is really an assumption, and if you have a weak point in Fick method, in all scenarios it will be that point, that oxygen consumption is not fixed unless the patient is normal, and not in the case if the patient have a hypervolemia or hypovolemia or have a low cardiac output. Second thing, that in the single ventricles, actually we said if we have a TGA, so actually we have a parallel circulation. In the equation that Fick method used, we have a starting and ending point of the circulation, but it's not the same in TGA. So he started the pulmonary circulation by pulmonary artery, and this by pulmonary vein, but it's not the case in TGA because it does not a circulation in series, it's circulation in parallel. Sometimes we said, okay, we can exchange the place of the great vessels, so it is transposed, so we can put the pulmonary instead of the aorta and the aorta instead of pulmonary. This trick is not actually 100% correct, because in the VSD, if the VSD is large, you have a blending. So actually the both circulation are not separated anymore, so we have a blending like we mentioned in the previous lecture that is blended. So this 3 points actually makes the numbers from Fick methods are meaningless, because you estimate the flow under certain assumption which does not go in the TGA. We don't have a constant consumption for the oxygen in systemic and pulmonary because it's either hypervolemic or the low cardiac output in TGA patients. The second thing, that the starting and the ending of the circulation in Fick method is in series, but in TGA it's in parallel. And if I have a VSD, it could be a blending, so it is not the input for the same circulation like this. Say Hatem.
So I would say measuring, calculating Qbqs with fixed method in the TGA would rather calculate effective flow, not total flow. And actually, effective flow is a really small fraction of the total flow.
Exactly.
So it does measure amount of oxygen crossing to the other side and then being extracted. But then, if you want to check how big is that pulmonary flow, which affects pulmonary vascular disease, heart failure, and all the clinical manifestations, this would not be measured by
CAT,
the
because
fixed method.
the Fick method estimate the flow. So actually back to basics again, that's why in this lesson I would love to explain Fick method, because Fick method say it's extracting a tracer. Just we subtracted the tracer amount from the beginning and the end of the circulation, but it's not the case in the transposition because we have different constant. We don't have the same beginning and ending for the circulation that in series. The third thing that we have a kind of blending or streaming that we don't know in the middle. So when we look for the other imaging modality that we have, echo is not more in the practice. In old days, 20 years ago or something like that, we put some effort in echo to measure the QP and QS with some mathematical estimated way, but actually it showed up that it's not accurate at all, so echo is not in our equation. We have cardiac MRI, and in the cardiac MRI, it's a gold standard for measuring the flow. Actually, the cardiac MRI is the only way, invasive or non-invasive, is the only way in the imaging modality to measure the flow in the blood vessels. CAT estimate the flow, not measuring it. But I will show now how we measure the flow. We have this sequence in the cardiac MRI. It's the Doppler of the MRI or the flow of MRI. We cut the vessel in a perpendicular way, so we transfer all the vessels to a circle, and we have this circle in the whole cardiac cycle in systole and diastole, and all images in cardiac MRI started with systole, with the peak, the peak of the arc. So we start in systole and we scan in systole and diastole, and with algorithm on the post-processing we drew contours, the area under the curve, all over the cardiac cycle. So this is what we do by the flow, that we drew contours over the vessel into systole and diastole. Then we have this XY. The X here is the cardiac cycle. So we have here the starting something like 700 milliseconds or 800, and the Y will be the milliliter. And as I said, we started in systole. So we have here the bulb is opening, we have here the peak systole, then we have the descending lamp, then here at the 0 point where the bulb closed. So we expected no flow. It should be zero flow. But if we have flow, reversal flow on the other side, we have this is the leaking, the backward flow or the leaking from the bulb. And from the area under the curve in systole and diastole, we are able to measure the flow across any blood vessel, aorta or pulmonary or any blood vessel like that. Actually, we are measuring milliliter per cardiac cycle. So the MRI, the only method to measure the flow in milliliter. It doesn't matter if it's oxygenated, non-oxygenated, if it's a flow, it's just a fluid hemodynamic. So the MRI is the only way to measure accurately in these contours, in this short circle that you made on the blood vessel, to measure the flow exactly milliliter per heartbeat. Then you are able to measure the stroke volume after that. This is the advantage in cardiac MRI, that we averaging the samples in the contours that we draw around the blood vessel, make the MRI the best modality to measure the flow, but not the best modality to measure the velocity. Again, the strongest point in MRI, that we draw contours around the blood vessel all over the cardiac cycle in systole and diastole, so you know exactly how much flow across this circle, because we're averaging all the samples. In the velocity is the same. If I would like to measure the velocity, this is the cardiac cycle, and Y will be meter per second to measure the velocity. But again, the software will take the average of all the samples that we have. So for example, if I have maximum velocity of 5 meters in one pixel, and I have 0 velocity in the other pixel, so what MRI will do, you will calculate 5 plus 0 divided by 2 will be 2.5. So MRI is the best modality to measure the flow, but it is not the best modality to measure the velocity. It's underestimate the velocity. So in the current era, we measure the flow by cardiac MRI, but we don't depend on the velocity because it's the same concept. It's averaging the velocity, not the peak. We don't have a continuous wave in the MRI yet. We have an averaging velocity all over the cardiac cycle. So if I would like you to remember something, the cardiac MRI is the method to measure the flow, but it's underestimating the velocity. So it's not your way or methodology to measure the velocity across it. And based on that, MRI couldn't have a surrogate for pulmonary vascular resistance because we are not able to measure the velocity in the vessel. So here we said cardiac MRI is the gold standard for measuring the Qbqs because we don't estimate, we don't depend on a tracer. It doesn't matter if we have blood or we have fluid or we have honey in this blood vessel. We can measure exactly how millimeter per cardiac cycle is going in this circulation. But cardiac MRI is not suitable yet for measuring the pressure, neither is the resistance. So the case in that, if you have a TGA with large VSD of hemodynamic significant VSD, cardiac MRI calculate the flow, not estimating. In TGA with that, if the question about the Qbqs, go for MRI. If the question about the pressures and pulmonary vascular resistance, combine your MRI with cath. For safety of children, do that in one sedation. So put the baby for general anesthesia, do the MRI, and then send the cath, just a quick cath for pressure and for pulmonary vascular resistance. Is it clear?
Yeah.
So FIC method is old method, still good for the normal circulation, for the circulation in series, taking in account that patient shouldn't be in low cardiac output, shouldn't be in hyper or hypoventilation status, but cath FIC method is not your method. In TGA or later on when we come for single ventricle, it will give some numbers, but these numbers are meaningless. Go for MRI when you are dealing with TGA or single ventricle. Is that clear about that point? Okay. This was the part that I would like to link with the previous lecture, and now we will start the TGA repair. Any question about the previous part? Is that clear about how to measure Qbqs by MRI? Okay. For TGA repair, the aim of surgery in TGA to make the parallel circulation in TGA in series. So this is our goal. What does it mean? That oxygenated blood goes to aorta and deoxygenated blood goes to the pulmonary. We will go by different method about that. And the second goal is to correct the additional lesion like VSD, like LV tube obstruction, like coarctation. And the third one is to provide a near normal function status for those patients. So this is the goal of the TGA. As Hatem said in the previous lecture, we have different scenarios, different time presentation. We have earlier presenter, we have later presenter, but the aim to correct the TGA is to have these three goals. The main goal is to make the parallel circulation a series circulation. Okay. The history of TGA repair in the late 50s, the Senning operation, this atrial switch, and in mid-60s we have the master operation. Both of them are atrial switch, like we said before. Then in mid-70s, Hatem presented the arterial switch, and Prof. Yaqub presented also the arterial switch, but in addition he presented the staged arterial switch. We will not talk about it, but something for training of the LV. And in mid-80s, the world started the neonatal TGA surgery as routine. The arterial switch became the operation for repair of TGA. As Hatem said, the TGA with intact ventricular septum or TGA VSD, we will go for arterial switch as first option, and the second option for lead presenter will be master. So atrial switch and arterial switch. If you have a TGA VSD LV tube obstruction, you have different operation, Rastelli, Rev, Nikaido. What we will discuss today, the status post arterial switch, status post atrial switch, and status post Rastelli. The other two operations are not in the scope of this lecture, maybe in the advanced lectures, but these three mainly we will focus in arterial switch, atrial switch, and we will give some hint about the Rastelli. Is that clear about that? Okay. We'll start by arterial switch. This is some drawing about the surgical operation. So this is the TGA. This is the incision line. The incision line done above the valve, and they do coronary patterns. They dissect the coronary arteries from that. And the second point, they switch. So the pulmonary arteries became in front of the aorta, and the aorta go back. And this is the suture line, and they re-implant the coronaries in the aorta. Hatem will discuss that in more details, but this is a cartoon graph just to understand what we have to follow in that patient. So is that clear? Any point? Any question for Hatem about the arterial switch? So incision line, pulmonary become, and this when pulmonary become in front of aorta, and this overriding of the aorta, what this maneuver called? Lecomte maneuver and repetition of current. Okay. Before starting that, actually the arterial switch become the operation of TGA repair. In the current area, we have LDS mortality only 2% in before 90s. Keep in mind that this operation became the operation in mid 80s. So with some early experience, the mortality was around 15%. Most of that actually until recent is heart failure. It's acute or subacute LV dysfunction. Mostly due to imperfect transfer of coronary arteries. This is Kaplan-Meier Curve. It's published in 2008, but this is one of the best studies about that. The natural history in 50s for the TGA. This is the years. This 4 years, 8 years, 12 years, until 20 years. You see the natural. This is almost 100% mortality. But with the arterial switch and the atrial switch gives much better survival rate in the patient. Atrial switch is still good, but as in the first 10 years, slightly different. But in the longer term follow-up, you see the difference between both of them, and we will explain why. Okay, what we have to follow in post-arterial switch, we have to follow the LV function. And we have always a suspicious about the coronary arteries. If the patient is TGA BSD, we have to check for residual BSD. We have to check for RVET obstruction and the central pulmonary arteries narrowing, and the new aorta dilatation and the aortic incompetence, and I will go in details in that. So you have a checklist when you see a post-arterial switch about that. Okay, we will go for the coronary issues now. Coronary stenosis, actually the coronary stenosis due to the occlusion or kink or stretching as a part of the reimplantation of the coronary. Actually, this is one of the most cause of the early death. Percentage is low, but this is the main cause of death in early post-arterial switch. It should be reconsidered in any infant immediately post-arterial switch if the patient identified with low cardiac output, if we have LV dysfunction with evidence of regional wall motion or LV dysfunction in that baby. So keep that alarm in your mind that there is coronary reimplantation, and you have to check about that. Actually, the kink or stenosis not only immediately post-operative, but it could be over the time. So you have to follow the patient with arterial switch over the time. Here I present one of our patients that this is immediately post-operative, and this is actually over 3 or 5 years post-operative. What you see in that picture, to the left is immediately post-operative, and to the right is the follow-up 5 years post-operative. What's catching your eyes in that? What about the LV? LV becomes more dilated. What about the function of the LV? Impaired function, right? So this is a post-arterial switch in a term of intermediate or long-term follow-up. And this is again, this is the mitral regurg immediately post-operative. How do you quantify that? Mild, moderate in the best, but this mitral severe with this impaired function. So we have LV dilatation, we have impaired function, we have severe mitral regurg, and this is the short axis. Look here, contractility is good. Here we started to have segmental wall motion, actually the anterior wall is not contracting, and septal wall is hypokinesia. This raise a suspicious about the coronary. What is your imaging modality? MRI for what? For viability. You mean for viability? Yes. This is but for the anatomy, CT. So you have to keep it low profile in any patient. Actually, the images here is very striking. That this is a follow up 5 years. So we have seen the major change in the LV function, in the volume, in the mitral regurg. But you have to keep an eye about that. Any change in the segmental wall motion, any change in the LV function, keep it. So this is the CT. Actually, I focused here on the point. This is the aorta. This is the pulmonary, and look for that. You see the ostial narrowing, and this is orthogonal on top of that. So this is an ostial narrowing in the reimplanted left main. That you don't expect in this young adults. You don't expect atherosclerosis. You don't expect a plaque, but you expected a narrowing in the side. Actually, this patient wanted to reoperation, and it's reimplanted in the left main, reimplanted again, and the mitral valve repair for that mitral, and the patient is doing quite fine. As our colleague mentioned here, Mona, that MRI is very useful to detect how viable or inviable this myocardial, how affected is it. Actually, doesn't matter if you don't have fibrosis, the patient have to go for reimplantation of the coronary, but MRI will be your imaging modality to detect that. Before going for CT, due to the hazards of radiation, you can do stress MRI. Stress MRI, this is adenosine or dobutamine. You can exercise the patient and you detect this is ischemia. Might be this is an imaging modality if you find a moderate stenosis in the ostial of left main, not that severe as we recommend in that patient. To think about how to document ischemia in your patient. So either do an MRI for viability, do an stress, normal treadmill exercise. You can do a pharmacological stress about that, but you have to document ischemia. For sure, you can do IVUS or FFR. You have to collect your evidence about that just to be sure that this is ischemic pattern about that. So LV function is mandatory. It could be immediately post-operative. It could be over years. You have to think about the coronaries in that. Okay. The second point, we have to detect the residual VSD. Actually, the presence of VSD increase the risk of arterial switch. The presence of single VSD increase the risk of death compared to the intact ventricular septum. So actually, as we said before, the TGA intact ventricular septum is a simple TGA. If we can call a TGA a symbol, it's a simple TGA. Presence of a single VSD increase the risk of the mortality. So if we have multiple VSD, it will increase the risk of mortality.
So this was well known early on in the early description for the results of the arterial switch. In later studies, this has not been shown to affect mortality.
Okay.
So currently the VSD in most countries would not increase the risk
mortality?
of operation unless the patient himself is having VSD with a hypoplastic arch, and then it's the problem. Most current problems are related to difficult coronary
Anatomy. And what about the complex VSD, like the complex VSD?
So the vast majority of the VSDs, they do not increase the mortality unless they are also associated with something like the toxic being with coronary deviation or a hypoplastic arch.
And that, okay, RV obstruction. It could be to the complex coronary pattern that requiring large coronary patterns. Hatem may agree with that, or he can give some input about that. If we have smaller new pulmonary trunk, the new pulmonary trunk will be the aorta, the old aorta, it will be the new aorta. If there is a discrepancy between both of them, it will be smaller new pulmonary aorta. Lecompte maneuver nowadays have been improved by augmentation of the pulmonary, but Lecompte maneuver was a reason of RFT obstruction. You would like to say agree or disagree with the complex coronary? It could lead to the RVT obstruction. Okay. Is that clear about that? That we're following it up. We have to check the LV function. From the RV we have to, and the residual VSD, and from the RV we have to see the RV obstruction and pulmonary artery narrowing. Pulmonary artery narrowing occurs in 10% of post-arterial switch, and in the children it could be easy to detect this pattern. This is modified suprasternal view. We have here the aorta, and we have the RPA and the LPA overriding the aorta, and we can see here some aliasing protuberance because the pulmonary arteries are stretched over the aorta. We could have an ostial or proximal origin stenosis from the pulmonaries. Nowadays, surgeon tends to augment the pulmonaries, so it becomes less frequent. But in children, it's quite often that you have this clear view by echo. But when the children grow up in the adulthood, this window will close, the suprasternal window will close. So your imaging modality, either 3D CT, so you have this beautiful reconstruction. You can find here the narrowing part from the pulmonary arteries. MRI also in adults could have some useful information. This is MRI sequence without any contrast, or so this is an MRI sequence in a clear way. You can find the peripheral pulmonaries. You have to answer this part in your checklist, either by echo in children, or you go for cross imaging modality, either CT or MRI for that. Many here in the guidelines, this is the guidelines about intervention and transposition after arterial switch. So actually they offer a surgical, this is class 1C. They offer surgical repair of RVUT obstruction in symptomatic patients if the RV pressure more than 60, and they overlooked the symptoms if the RV systolic pressure will be more than 80. This is class 1C, and this is class 2AC. So surgical repair for RVT obstruction should be performed in any symptomatic patient if the pressure is more than 60, and regardless of the symptoms if the pressure is more than 80. And the surgical repair of RVT obstruction should be offered for the patient regardless of the symptoms if the patient have an RV dysfunction that developed over that. This is class 1C. Actually, this is have some evidence about that. Okay. They talk about the stenting or surgery of peripheral pulmonary stenosis according to the experience of the centers, regardless the symptoms. If it's more than 50% narrowing of the diameter, or you have RV pressure more than 50, or you have lung perfusion abnormalities. So actually in clinical practice, we can easily detect the narrowing in the diameters if it's more than 50, and the RV systolic pressure is more than 50, regardless the symptoms. They offering stent for that, and this is class 2AC. So we still have some evidence about that. Is it clear? So in post-arterial switch, you have to follow the RVT obstruction and the peripheral artery narrowing. Okay. The new aorta is not the aortic valve, as you remember that they transected the vessels. So this was the old pulmonary, it became the new aorta, and this is intrinsic factors in the post-arterial switch. The new aorta will be dilated, and we will have an aortic incompetence in 3% of our patients. Mild regurgitation of the aorta is common, plus or minus the aortic root dilatation. Aortic incompetence increases slowly by age. Moderate root dilatation is common, however, reported there is. I don't recall any cases that reported dissection about that. It's easy to detect the aortic incompetence like we do by normal aorta, and CT or MRI will be your measure to detect the aortic root dilatation. The guidelines here about the intervention in that case, that aortic root surgery should be considered when the new aorta, they put new between brackets because it's not aorta, it's pulmonary that became an aorta, is larger than 55, providing an average adult structure for aortic valve replacement for severe aortic regurg. We still have some debates about that. We copy paste the same indication from the aortic valve, but nobody knows is it 55 should be our cutoff point or not. Still multi-center studies is going on top of that. but this is the current guideline. They give evidence to AAC for that. So yes, we follow up the aortic incompetence in patients after arterial switch. However, no cases reported for dissection yet about that. It's dilated, but we know why it's dilated, because it's not aorta, it's pulmonary, behaving in aortic position. Is that clear now for that? Okay, take home message for arterial switch. Arterial switch is a safe operation. It's low mortality, but the aerial arterial switch is the safer because LV is still condition. Coronary anatomy is important, as Hatem mentioned. They have some complex coronary anatomies. Intramural courses is one of their difficulties. Coronary reimplantation in a proper way sometimes couldn't be achieved, which affect dramatically the LV function. And longer term follow-up is needed, either for coronaries, either for pulmonaries, either for aortic root dilatation. Is it clear now about that? Okay, any question about the arterial switch?
How often should I send my patient
It
for
would
CT?
For CT?
For CT.
When you have a question about that, when you have
Yes.
and you can replace when the patient is grow up in the adulthood, you can replace the CT simply by MRI for measuring the pulmonaries, for measuring the aorta, because this is quite big structure. But CT is still mandatory when I have question about the coronaries. When you have an indication, as I said, you have to document that your patient is ischemic.
Not a regular CT.
No,
every 5
not a
minutes.
regular, not at all. But this patient does not leave the clinical, so they follow up with the adult congenital heart disease clinics. Depends according to their symptoms, either annually if you find progressive changes, or one time at 2 years. But they never leave the clinic.
Should I ask for a Holter every now and then in those patients?
Actually, not in arterial switch. Arterial switch arrhythmia in arterial switch is not that frequent. It could happen. It could happen in that, but according to the same prevalence in other. When we talk about the atrial switch, they have more. The arrhythmia is an issue in the atrial switch, but in the arterial switch, it depends. It depends. It's not that common. It might be you have an arrhythmia because your patient is ischemic, so you have to detect the ischemia from the first start. But the bottom line, arterial switch does not leave the clinic. It's just follow up, and I think that the eldest arterial switch is only 43. I think the eldest is 45, something like that. They are 45, something like that, because the first arterial switch was in 75. So actually the 75 nowadays is 47 and 47, yes, and I'm 75, so I know exactly that they are 47. So, and the neonatal arterial switch became practice in mid-80s, so they still around 40s. So this is our experience when the arterial switch became 40s, but we don't know when they became 50 and 60. Still we gathering the information about that. Is it clear now about arterial switch? Checklist about the arterial switch, coronaries, and the LV function and if you have residual VSD, you have to detect it, and you have RVT obstruction, pulmonary arteries, and the aorta, neonatal aorta, new aorta root, and the aortic incontinence. Is it clear? Okay. We will talk now about the atrial switch. Actually, we talked about the arterial switch. Historical atrial switch is older operation or well-known operation for the atrial switch for TGA repair, but arterial switch is the operation currently. So you do the arterial switch. If you couldn't do the arterial switch, you do the atrial switch. Okay, the atrial switch, as Hatem said in the previous lecture, the interatrial septum is removed, and the redirection of the pathways for that. So the systemic venous go for the LV, then go to the pulmonary, and the pulmonary veins redirected to the RV, then go to the aorta. So actually, we have here the parallel circulation became a series. We changed the color in the color in the arteries, but we didn't change the arteries itself. Is that clear? So here actually the systemic veins go to that way, and this pulmonary veins go to that way, it ended up that aorta received the oxygenated blood and the pulmonary received the deoxygenated blood. So the first goal, you remember the goal of the TGA repair, that the paracirculation transformed to serious circulation. Sending operation, actually this is a native, was the first operation. In a simple way, master we use synthetic material or pericardium in the tissue, but sending the rerouting by enfolding the atrial walls itself. Okay, is it clear about that? So you understand now why we say the atrial switch is physiological correction. Why it's physiological correction?
Because the RV is still facing the systemic.
Exactly. We have here that we change the color in the great vessels, but the connection is still abnormal. It's still transposed great vessels in that way. Okay. Again, this is the curve that we show in the post-arterial switch. So actually, in the beginning, the difference between in the early follow-up, the difference between arterial and atrial switch is not that big. But when we came and 15 years follow-up or 20 years follow-up, we see the difference, the deviation, that atrial switch show low survival curve compared to the arterial switch, and we will understand now why. Do we have to check the coronaries in that patient?
We don't manipulate the word.
They didn't do our coronaries are in the coronaries. So we do a lot of buffling, so a lot of cutting in the atrial walls, actually enfolding of the atrial walls, incision, or just a lot of incision in the atrial walls, and we do buffling. This is in synthetic materials or the pericardium inside it, so we do buffling for the systemic veins and for pulmonary veins. So we expected to check the pulmonary, the baffles. Baffles could be stenotic, could be leaking. So we have to check the baffles. If there is any complication, it's stenotic or leaking. As you said, that RV is still facing the systemic circulation. So in that case, we have an RV as systemic RV, and we have to deal with that. As I said, that we have a lot of cutting and a lot of scars. So atrial arrhythmia is an issue in the follow-up of patient with after atrial switch. Okay. The baffle problems, the intra-atrial baffle is vulnerable, and they could become degenerated, stenotic, and they could leak, just like a hole in the baffle. Okay, this is the baffle. We have superior vena cava baffle, inferior vena cava baffle, and we have the pulmonary veins redirected to the right ventricle. So both superior and inferior vena cava baffle could develop stenosis. In master, less common that pulmonary venous baffle have stenosis, but the superior vena cava baffle is more frequently affected. Actually, it's by 5 to 15% from our patients developed superior vena cava baffle stenosis. Again, we can follow them by echo in children because they are small, and the penetration of echo is good, so you can see some parts of the baffle. But if you deal with the adults, you have to do for cross imaging, that will be MRI or CT according to your experience. This is how it goes here. This is the echo. So we have here the tricuspid of this is the offsettings. This is the LV, the RV, and this is the LV, and we have here a limb with some color here. This is the knob of the probe, so the flow is going from up down. This is the superior vena cava baffle, and show some aliasing, and we confirmed that by MRI, and we see some narrowing in the limb of the superior vena cava. You see, this is superior vena cava, and it's redirected here, and we found some stenosis here. Is it clear about that? Everybody see it? Everybody see it? That this is aliasing of the color. Why the color is red? Because it's going to the knob of the probe. Why this color is blue? Regurgitation. Tricuspid is over the systemic RV. Exactly. This is the regurgitation. Exactly. So we have here some narrowing in that. Actually, superior vena cava baffle stenosis is the most common one, and it could gone unseen. Actually, it could be clinically silent. Why it could be clinically silent? Because often the azygous vein recanalized again. So this is very common in mastered patient or an atrial switch patient, that they clinically silent about that. This is an MRI that showed here. I might stop this one, it goes very fast. This is the aorta, and this is
Azygos.
azygos. This is azygos. When you go back for that, you see the narrowing here. You see the narrowing here. This is the superior vena cava, and this is the buffle, and this is the narrowing here. Is it clear?
Yes.
This is the. So what happened here? That this patient remained asymptomatic until they decided to put a pacemaker. So when they go from the superior vena cava to the subpulmonic, they found an obstruction. So although the superior vena cava buffle obstruction is the most common obstruction, but it could be clinically silent. But again, this could lead, although that it will not present by superior vena cava obstruction syndrome. This is the bottom line, will be presented. But again, this reduces the exercise capacity as venous return will be limited. So if you discover superior vena cava limb obstruction, you have to correct it, even if the patient is silent and not presented by superior vena cava obstructive syndrome. For the inferior vena cava buffle, stenosis is less common, but also less tolerable than superior vena cava obstruction. As I said, superior vena cava obstruction, usually the azygos will reopen again and will not presented by superior vena cava obstructive syndrome, usually. But inferior vena cava buffle will lead to venous pressure, so on the liver. So this patient will presented with ascites and hepatomegaly, and this problem will be manifest and clinically oriented, and you have to deal with it. This is the buffle. This is an MRI. This is the buffle of inferior vena cava, and this is the junction between the inferior vena cava and the supraleft ventricular chamber here. And this is the flow, and you see some aliasing in the flow here. This is white, and you see some black color here. Is it clear? This 2 points here. This is a color flow. You understand that? This is the inferior vena cava going here, and we see some narrowing anatomically in that point. At the same point, you will find 2 voxels of aliasing in that. Is that clear? Clear? Okay. For the pulmonary venous, it's not a problem for mustard, but it's problem for thinning. So if you, on the long-standing thinning operation, usually they got pulmonary venous obstruction, but not a problem in mustard. And currently, most of our patients have a mustard operation. What do you see here? This is the pulmonary veins redirected here, and here we have leak. Exactly, it's a tear in the buffle. So actually, it's buffle leak here. So buffle leak. Actually, in most of the cases, I will not go for the rare cases. It's left to right shunt, so the patient will be overloaded. With large buffle leak, they create problem volume overload on the pulmonary circulation and the atrial. It depends on the size of the shunt. If it's a small leak, it will pass unnoticed, but if it's a large leak, it will be volume overload, and it have to be tackled. Stenosis have to be tackled usually percutaneous. They can dilate it, they can stent it. It could be surgical, but intervention now could help in that problem. In buffle leak, we have to tackle this problem surgically. You have to close this leak. So again, small leaks could pass unnoticed, but large leak, the patient will present it by, in most of the condition, will presented by left to right shunt, and the patient will be volume overloaded.
So the LV here will be dilated?
LV will be dilated because it's more to the okay. The second thing about right ventricle here is supporting the systemic circulation. So this will be what you see here. The geometry of RV will be distorted, and the geometry of the tricuspid valve. Tricuspid valve here is a systemic valve. Usually this patient presented by the severe tricuspid regurg and impaired systemic left brain. You remember the Kaplan-Meier curve that I show you to you? After 20 years of the operation, they started to show a difference between arterial switch and the atrial switch, mainly due to the systemic RV failure. So in the early decades of life, they behave in a good way, but later on, this patient will suffer from a cardiomyopathy or RV failure in that. Okay, echo is not the best method to detect the volume or geometry of the RV. CMR is the gold standard about that, but again, gold standard, define the gold standard in systemic RV. Actually, this is another dilemma in evaluation of the master test. So you have a dilated RV, you know it's dilated RV, but you don't have a cutoff value. You don't have a cutoff value, for example, like 200 millimeter per meter square. This is a red flag. What we do currently by MRI, that we do routine in MRI to compare each patient with himself. So we do routine MRI every year or 2 years in a mastered patient, or when the patient becomes clinically symptomatic, just to compare each patient with itself. So most of the centers go for a baseline study when the patient is in a good condition, just to compare what's changed. But we don't have a reference number like we have for the normal patient, because we don't know what should be the normal figure or accepted figure when the RV became the systemic ventricle. This is an answer question. Again, the new aorta in arterial switch is an answer question, because this is no aorta, it's not aorta. This is a pulmonary behaving in aortic position. So there is no gold standard. Again, no gold standard numbers for the RV. Each patient is a reference for itself. So we know that the patient will be in a good condition immediately post-operative. So when you can put the child in the scanner at the age of 10 years or age of 8 years, just do a quick MRI just to know the what is the normal for this child, and compare each patient by himself over the time. Is that clear? We don't have a reference number for what is the normal systemic RVS. Does not exist in these numbers. Any question about that? So echo is not your imaging of modality, because RV is dilated out of the scope and to be complete in one volume of echo, and do MRI for that patient. Okay, atrial arrhythmia. As you can imagine that the atrial switch have many scars, have many incisions in the left atrium. So actually, most of them have a sinus node dysfunction. The mechanism, either damage of SA node or SA node artery. The surgeon, Hatem, might talk about that. They try to improve the practice to avoid damage of SA node branch in that.
Yes, so the problem here is anatomy of SA nodal artery is variable. So most of the time we know the site of the SA node itself, but artery to SA node can have variable courses. So we tend to avoid the most common places where the artery crosses, but then sometimes this is not totally achievable. Most of the time we need to cut out the upper part of the atrial septum so that the communication between both atria is wide enough so that it can handle 3 pathways, because now three pathways will have to cross the site of the original atrial septum, the SVC pathway, IVC pathway, and the pulmonary veins. So if we do not excise the atrial septum big enough, you tend to get baffle obstruction. But on the other hand, if you cut it too much, then you have more risk of injuring areas where the SA nodal artery would have crossed.
Yeah. So as Hatem explained quite well, this is a complex maneuver. Again, we have to solve the problem of barrier circulation by having circulation in series, but at the expense of unexpected scars on the atrium. So actually, SA node dysfunction is a very common problem in the post-atrial switch. About that, many patients will have an atrial arrhythmia. This figures from what is currently in the world about master. They do mapping about that, just as they try to ablate the focus of the arrhythmia in that. So this is really a big burden on the clinical practice. Atrial flutter, actually, after 2 decades of surgery, third of the patient will experience at least one attack of the atrial flutter. Again, the scar lines will, due to the sutures, actually the substrate of the atrial arrhythmia. For the clinical practice, you have to do an ECG. For any patient, you have to do ECG. But if you find a mastered patient with heart rate more than 100, do a vagal stimulation, just carotid massage or Valsalva, just to dissociate the P wave. You'll be astonished that more than 50% of your patients that you diagnose them as sinus tachycardia and just describe some beta blockers or check an anemia for them, they are an atrial tachycardia. This is very common in the practice. Actually, this was a good advice from an EPS conference, that in each patient after atrial switch that the heart rate is more than 100 and you consider sinus tachycardia, do vagal carotid massage Valsalva. You will find an B wave dissociation, and this is an atrial tachycardia. It could be controlled by medical treatment, but it could need an ablation now, and there is big success in the ablation in that way. Again, remember that this patient have right ventricle as systemic ventricle, so atrial kick is really needed. So when the patient have an atrial arrhythmia, your patient will be decompensated. So keep in mind in the practice, not in the arterial switch, but in atrial switch, you have to follow the arrhythmia. That's the answer for your question about that. Arrhythmia is a hot point in follow-up of atrial switch. Is that clear? Okay. We have a lot of literature about the follow-up in natural history about the masters. So actually, this was a Dutch group. They follow up their patients for 40 years, as you expected. Many patients have a mastered operation. They conclude in their paper they published in 2014 that 40 years after master operation, 2/3 of our original cohort are still alive. There are progressive decline in the right ventricular systolic function and the increase in the incidence of arrhythmia and heart failure. However, the functional capacity remains stable. So again, systemic right ventricle arrhythmia is the cause of the death for 1/3 in this cohort. This is another publication that long-term outcome after atrial switch in the Denmark cohort. Their conclusion was the long-term survival of our patient after either thinning or mastered correction of TGA appears to be primarily determined by factors of the right ventricle and tricuspid, and not by the time or type of surgery in childhood. So again, the systemic right ventricle and the arrhythmia and geometry of tricuspid is important. Cardiac function necessitating to have an implanting a pacemaker associated with increased mortality. Again, arrhythmia. So in the atrial switch, you remember the Kaplan-Meier that decreased because of the systemic right ventricle failure and for arrhythmia. Unfortunately, not in our countries, transplant is their option after that. This could be an option for them, but this is what we have to follow in the patient with atrial switch. Again, what we have to follow after atrial switch? Buffers, RV function, arrhythmia. You have to expect an atrial arrhythmia. If your patient have a heart rate more than 100, expect an atrial tachycardia. Okay. Now we will give some hint about that. If you have a TGA DPS, so you have to transform the barrier circulation into a series. So this could be, first thing, I'm describing Rastelli, an intracardiac baffle to tunnel the LV to the aorta. So here the oxygenated blood will go to the aorta, and you have to secure that the oxygenated blood will go to the pulmonary. This is an external valve conduit connect the pulmonary artery, RV to the pulmonary artery. Is it clear? So Rastelli actually is this operation. The Rastelli operation is done by Rastelli as surgical repair for TGA VSTPS in late 60s. Actually, still the operation for the repair of the patient with mortality, with low mortality. Actually, the mortality in most institutes is around 5%. But again, what we have here, that most of the patients of Rastelli will undergo to the reoperation, either to repair the intracardiac pathway or to repair the extracardiac conduit between the RV and the pulmonary artery. So what we have to follow in Rastelli actually is the LV function as equal as to the RV function. Exactly? Do we have to check the coronaries in Rastelli? No reimplantation of the coronaries. So actually the LV dysfunction will be due to, if you have an LV dysfunction, it will be due to LV obstruction. And if you have RV dysfunction, it will be due to either. Exactly.
So, LV affection, LV failure here is, as you say, mostly because of LV obstruction, because of the long and pathway almost at right angle, but also sometimes with the advanced RV failure because of conduit problem, you also get LV secondary to RV.
This is
usually the LV who causes the RV to deteriorate after how the RV would make the LV function like that.
Again, because if the pathway from LV to aorta is wide enough, so it usually lasts, unless this was done in a very small baby and then he grows so outgrow that long buffer, or if there was some narrowing to start with and then it progresses. This is the LV obstruction. But the RV to PE conduit obstruction is inevitable. So almost all patients will get degeneration of that conduit. And then if you stay long enough with a degenerated conduit, you get advanced RV failure. And sometimes people will tend to delay intervention so that the number of required intervention are less. And then you by time you get also LV dysfunction. And then you're faced with a patient with biventricular failure, which is currently with the advance in the percutaneous valves, the indication for intervention for RV degenerated conduits should be actually more frequent.
exactly. So actually, Rastelli operation, as we said here, the mortality is less than 5% in most institutes, but the requirements of re-operation in Rastelli is actually very high, and this is so for the intracardiac tunnel. It's easy to follow up. So we have here an LV, and this is the intracardiac tunnel. You look at LV, something is going like that. Yeah, it's going like that. So here, the LV obstruction either due to incorrect placement of the intracardiac baffle, like Hatem said. The bigger the baby, or the bigger the child will be the best. So actually, they started to say that the age of 4 is the most suitable age to start to do Rastelli, just to have a place to put your intracardiac baffle. Again, sometimes you have you might need to enlarge the PSD. This will be expense on the at risk of complete heart block that will end this patient have pacemaker. If you remember in the master, they said the mortality is higher when you need a pacemaker just to keep the rhythm for your child. Okay, this is the extracardiac conduit. As Hatem said, when you put RV to be a conduit, the clock started to ticking. So each conduit have lifetime. They will degenerate after that. So we expect that this patient will need a replacement for that conduit after a couple of years, and we try to buy sometimes for that. So this is the external conduit from the RV to the pulmonary and how it looks like. Yes. And this is how it looks like. It's a stenotic. Again, as we said, in all cases, in children it's easy to find this because it's not in the normal position. It's more anterior, just behind the sternum. So in children you can do it by echo, either by the normal views like we mentioned in previous lecture. But when the patient grow up, all these windows will be closed, so you have to do for cross imaging like MRI I said in that, or by CT. You have to do a cross imaging modality to find that. So this is a stenotic pulmonary valve or RV2BA conduit, and you have to replace this conduit. This is another example how it looks like. So the degeneration is here is the beginning of the conduit. This is the calcification inside that.
Can you see the conduit eroding the sternum?
Here. kind of complication for that, so you have to be careful for it. So either CT like this one, or like the MRI. In MRI, we can see the buffling of the LV to the aorta and the RV to pulmonary for that. In Rastelli operation, I said the patient 4 years or older at the time of Rastelli operation require few operation, especially for the intracardiac tunnel. Conduit change operation is required in the most of the patient, regardless the technique that you use, because it will degenerate over the time. In previous days, we do it surgically, but currently, intervention like percutaneous pulmonary valve replacement or melody implantation in the pulmonary valve, it could help in the lack of percutaneous.
So interestingly, RV2PA conduit after Rastelli degenerate a lot faster than RV2PA conduit done for Ross. And this is probably related to the position of the conduit. When we do the Ross, you take out the native pulmonary route, the patient's native pulmonary route, and then we put the homograft in its place. So it's put in an anatomical position. While in the Rastelli, the conduit is placed along the free wall of the RV. So you cut an incision in the free wall of the RV and connect that from the free wall into the PA bifurcation, and this is an extra anatomical place. And it was found that same homografts placed in this position would degenerate a lot faster than being put in the anatomical position.
Having said that about the Rastelli, what do you think that advantage of Rastelli?
Keep the LB as a
Keep the LB as a systemic. This is actually switching the ventricles in that way. So actually, as you mentioned here, Rastelli is hitting both the ventricles, so you have to keep an eye about the LV function and about the RV function. If you compare it by arterial switch, you are worried about the LV function. In the atrial switch, you worry about the RV function, but here you worry about the two ventricles. But the advantage of Rastelli is you still have LVS systemic ventricle, and this avoid all the problem of systemic RV. As we said, maybe we hope that percutaneous intervention will help the problem. If we do the operation in older children or in the bigger size of the children, the intracardiac buffalo will be okay. And for the RV2PA conduit degeneration, we hope that percutaneous intervention will lead to less operation needed for these children. Okay, so I think that I'm done about that. To recap about what we have said, after arterial switch, what you have to follow: that LV function, think about the coronary arteries, check for the residual VSD, because arterial switch is for TGA with the intact ventricular septum and TGA with VSD, check for the residual VSD, check about the RVT obstruction, and for central pulmonary arteries origin stenosis, and check for the aorta, new aortic root and aortic incompetence. In atrial switch, you have to check for the buffle. Buffle could be stenotic and could be leaked, and you have to evaluate systemic ventricle. As I mentioned, systemic ventricle, systemic RV ventricle, no gold standard, no reference. Each patient is a reference for himself in his clinical journey. For the Rastelli, keep an eye for both ventricle. LV function will be deteriorated due to the LVT obstruction, and the RV function due to the RVT obstruction. That was all. Thank you. Any questions?